Hello, my name is Latasha Stout. This is part three of my cognitive psychology project. So let's get started. We all know someone who suffers or has suffered with dementia. For me, it was my grandfather who died in a house fire from the effects of this disease. Mild cognitive impairment that can advance to dementia is a growing concern in the world today. Right now, there is no cure, but we can slow the progression of this disease's decline. Let's get into it. This presentation is on the memory impairments in patients with dementia. We're going to deal with cognitive difficulties, which happens in patients with dementia, and also memory loss, specifically semantic memory, which is memory of facts. First, let's discuss how we assess if there is a cognitive dysfunction or memory impairment. Some cognitive modeling is, I know one that was done by Johns and some colleagues, which is the verbal fluency task to assess cognitive dysfunction. He stated that this was widely used for to test for semantic memory functioning. And with this one, you would place, you would group items together, and after a delayed time, you would recall verbally um, items in those groups just to test your cognition. Another modeling tool was performed by Salmon and colleagues. There are more types of cognitive models that can assess cognitive dysfunction, such as memory impairment, and those are the letter fluency task and the semantically based category fluency task. And the letter fluency task involves specific letters where you still had to do, there was a delay, but you get to recall letters in specific groups. Then there's the semantically based category fluency task. And this one you would group specific things together like animals or fruits. And both of these, like I said, there's a delay between each time you have to recall. Those are just tests and assessments that you could do to discover whether or not there is cognitive dysfunction or memory loss. After knowing how to assess cognitive impairment, how do you know when to assess or look for early signs of cognitive impairment? According to Carr and colleagues, sometimes dementia doesn't even get diagnosed. Um, like people would have impairments 1 to 11 years prior to the definitive diagnosis. One of the biomarkers to look for, as far as what Carr stated, was finger tapping. So that would be one thing that you could look for. It's best to get diagnosed early. So looking for biomarkers is good to be diagnosed early. In order for any slow of progression, you would need to be diagnosed early with any type of mild cognitive impairment or mild to moderate dementia. What are some of the possible contributors to memory impairments in patients with dementia? Let's discuss some modifiable dementia risk factors that have been researched. Bransby and colleagues researched 5 modifiable dementia risk factors which can contribute to the disease. One would be mood symptomatology, like depression or any type of poor mental health. Another one is risky lifestyle behaviors, and that would be something like a poor diet. I've also read in with my current job, I've also read that alcoholism can also play a part in some memory impairment. Cardiovascular disease, such as hypertension, with this high blood pressure. So we want to be careful with that. Cognitive, cognitive or social engagement. That's family or friends interaction. How poor or how healthy that is, but poor social engagement can be a contributing factor. Sleep disorders, excessive daytime sleepiness. You get tired during the day a lot. That could be a contributing factor. And sometimes sleep disorders are being caused by other things, such as cardiovascular disease. So, multiple domain modified dementia risk factors will increase the risk of getting dementia. So if you have more of these domains working together, you have an increased risk of developing dementia. Let's talk about how we can help improve cognition. Cognitive stimulation is at the root of my intervention in tackling the ongoing concern of memory impairment in dementia patients. Cafferata, and I hope I'm saying that right, and colleagues measured the effects of cognitive stimulation in dementia patients. And this is with mild to moderate dementia. Full blown dementia, it's hard to go back and try to recapture some of that semantic memory. But with mild to moderate, it's not as severe. This is non pharmaceutical. Cognitive stimulation is non pharmaceutical. So hopefully that is a plus. That is definitely a plus for me because we all know that drugs carry multiple risk factors in themselves, which could worsen the disease, unfortunately. This approach includes reality orientation, such as, repetition, stating your name and date daily, constantly. Validation and or reminiscence. Cafferata and colleagues have support that cognitive stimulation improves cognitive function. My intervention is cognitive therapy. In this process, I plan to revitalize and stimulate through similar methods of cognitive stimulation suggested by Cafferata and colleagues. The goal for my intervention is to slow the progression of cognitive decline in patients with dementia. I wish this was done when we discovered my grandfather had it, but by that time it was too late. Memory impairments usually happen in middle age to older adults. So that would be the target population. Medical facilities and staff, such as nurses, radiologists, because you need them to run the fMRIs in order to scan brain function, cognitive function, and neurologists who can read those radiology reports, and then cognitive psychologists who can also give us information from a psychological standpoint of whether or not the intervention is working. So we need those people for the assessment process. To implement this process, we would need to pilot this in a small group, I would say, within nursing homes, within maybe 1 or 2 cities for 2 to 3 years, and then with assessments and evaluations every 6 months. That's what this team of doctors and nurses and psychology staff would need to do the assessments every 6 months just to see if it is working before trying to implement this globally. And again, the cognitive stimulation is the main route for the cognitive therapy that I want to implement for this project. The hope is to help improve memory impairments in patients with mild to moderate dementia, to give them longer life and more time with their family before full brain deterioration, which happens in dementia patients. What did I learn from doing this project? Number one, dementia is a growing concern. It is much bigger than what I thought it was. I did not realize that it was such impactful information, or people are researching this every day, all the time, to try to help improvement. And there is currently no cure. So there's much work to be done. Even with the vast amount of research that's out there, we still need to do more research and try to get more and more interventions, because honestly, drugs is really a temporary fix. So if we could get it to where we can detect it early, I think that is the biggest factor. If we can detect it early, then we could help improvement, and like I said, give families longer time with their loved ones. So the conclusion, like I said, while there is no cure for memory impairments in patients with dementia, my intervention of cognitive therapy targeted at the semantic memory, which, like I said, is memory of facts, knowing your name, knowing the date, knowing what things are used for, we will be able to slow down the progression of cognitive decline in these patients. And that is all that I have. Thank you for listening to me. And hopefully, I have encouraged you to want to research and help with the decline in the memory impairments for dementia patients. Thank you. These rest of these slides are just the references that I've used, so you can feel free to go through those just to do some background work. Thank you and have a great evening.